The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety.
Thanks for joining us for another episode of the FAST Archives mini-series. Today, we've pulled another fantastic talk from FAST given by Jason Bartos, a critical care physician and interventional cardiologist at the University of Minnesota. What makes this talk interesting is Jason takes us through the pioneering steps taken across the Twin Cities with a groundbreaking program called ECPR, or extracorporeal cardiopulmonary resuscitation. This technique offers a lifeline for patients with refractory cardiac arrest who don't respond to standard treatments. With only a small fraction currently accessing this potentially life-saving therapy, Jason's work is critical in expanding its reach. Get ready to learn about a program that's not just changing lives in Minnesota, but could impact communities nationwide.
The first step for any cardiac arrest-based program is to know the data of your area, to really know how many cases do you have, how many cardiac arrests, of what type. So if you look at this data here, this is our data from Minnesota. From the years preceding our program, about 5 years worth of data, about 7,500 cardiac arrests overall. About a third of them were VF arrests. And if you look at the left side, that's total. And as you go to the right side of that leftward graph, you lose patients at every step of the process. You go to ROSC, you lose about half of your VF arrests. You go throughout the hospital stay, you lose a few more. And in the end, you have about a third of your total VF arrests that leave the hospital. And if you look at just those that get ROSC, it's about 2/3 of the people that leave the hospital neurologically intact. The question is, how do you get to those other half of the people that never get ROSC? The people that you may have worked in the scene for 30, 45 minutes without getting ROSC, and then at the end, you have nothing else to offer. ACLS is not enough, and there's nothing after that. That's where ECPR comes in. We specifically have targeted shockable rhythms because of the efficacy of CPR in that population. But there's nothing to say this couldn't be done with other cardiac arrest rhythms as well, if you can get to them fast enough and have a system for them. So as you're looking at this data that I'm about to present, keep in mind this is all for patients with shockable rhythms. But again, the rest of the patients are also eligible. We just haven't gone that far yet. So we started back in 2015 with a program based at the University of Minnesota. Patients would come to us. We worked with all of our EMS agencies in the Twin Cities, 7 of them in total, to bring us their patients. They would come straight to the cath lab and we would perform ECPR. I'll talk about what that means in a second here. We started the Minnesota Resuscitation Consortium's project in this. The Minnesota Resuscitation Consortium existed before this, doing other important work in the community around cardiac arrest, bystander CPR training, activating cath labs for patients with ROSC and shockable rhythms. But we really brought it to bear on this problem of those patients who don't get ROSC. We talked to our EMS crews about early mobilization from the field. Gone were the days of 30 minutes on scene. We target 15 minutes on scene. Enough time to assess, shock 1, 2, or 3 times, load, and then transport to us. Once they get to us, we're trying to achieve hemodynamic stabilization as quickly as possible. We're doing this with ECMO, extracorporeal cardiopulmonary resuscitation, use of ECMO for CPR. We then treat the underlying etiology. If you don't have stabilization, you can't treat that underlying etiology, but once you do, once they have a blood pressure, they have blood flow to their brain, now you can take the time to figure out, do they have coronary disease? Do they have an MI that led to this, and fix that underlying etiology? This is ECMO. Again, extracorporeal membrane oxygenation, the use of a large cannula in the femoral artery and the femoral vein to pull blood out of the body, put it through an oxygenator, give it oxygen, take off carbon dioxide, and pump it back into the femoral artery, bypassing the heart and lungs, providing basically cardiopulmonary bypass through peripheral vasculature. We have a pump that's made by McKay, the CardioHelp pump, which is about the size of a bread box. It is the brains. It is the pump that runs the oxygenator and the pump and gives us some data back as well. So we can get the RPMs and the flow, but we can also get the SVO2. We can get the temperature, the hemoglobin. We can get a sense of how the patient's doing and resuscitate them based on that data. To do this, we use a 15 or 17 French arterial cannula. If you take the French, divide by 3, that's the number of millimeters in diameter of that cannula. It is big. It is bigger than any other cannula you will use in a vessel. We use a 25 French venous cannula, bigger yet than the arterial cannula. So the biggest risk of this is access site complications, getting the vessels correctly placed in those arteries and veins, preventing bleeding, and providing this secure hemodynamic support. This is us doing it in the cath lab. We had the whole cath lab team. We had perfusion. We had our ECMO specialists. We had respiratory therapists. We had a whole crew of people who do ECMO in the hospital and other settings, and now they were applying it to ECPR. We also had the fluoroscopy and the cath lab staff who were used to where the supplies were and could manage it with that same sort of pit crew mentality, but now directed again to ECPR. This was our protocol. We asked the paramedics to find us patients that were between ages 18 and 75, that were not DNR, that had a shockable presenting rhythm. They could be shocked into PEA or asystole, but they had to start shockable. They had to be in refractory cardiac arrest, meaning they at least got 3 shocks if it was ongoing VF, or if they were shocked into PEA or asystole, that was fine too, but again, had to be refractory. We then had those EMS crews transport patients to us. When we receive them, we get that first bit of arterial blood from the femoral artery as we're getting access, and we test that as an ABG. We get their PaO2. We require that it's over 50. We get their lactic acid from that same blood sample and require that it's 18 or less. So pretty liberal criteria, but if they met those criteria, we would take them and we'd put them on pump. Once we put them on pump, we would then do the coronary angiogram, PCI. We could do everything we want to do for assessment. We could do pulmonary angiograms as well, looking for PEs, and we could fix underlying etiologies to try to get them out of that rhythm or out of that cardiac arrest. We then gave them 90 minutes. After all of that, there are a few patients that were still in VF. There were a very small number that stayed in VF despite everything we did. And if they did not come out of VF within 90 minutes of all that treatment and all of the additional medical therapy we could bring in multiple shocks, then they died in the cath lab. Otherwise, they were admitted. This was about 10% of the patients that did not come out of VF despite everything. But 90% were admitted. So now instead of a 50% ROSC rate for the overall population, we take the 50% that didn't get ROSC in the field, and now we give them a 90% ROSC rate, or hospital admission rate. We get them to the point where they have ROSC defined by the pump. We have a rhythm that is organized. It might still be AFib flutter. It may even be VT, but it's not asystole, and it's not VF. And we admit them to the hospital. We now give them a chance to recover where they didn't have that chance before. If you look at our numbers recently, about 478 patients, we're right around 40% survival for that group. So now these people who would have died in the field, they have 40% survival. But it takes a lot to get them through. There's a lot of trauma that comes with having about an hour of CPR. As I tell patients' families, good CPR is traumatic CPR. I'm sure you've all experienced that. Cracked ribs are just the beginning. Hemothoraces, pneumothoraces, abdominal bleeds, liver lax, splenic lax, all sorts of trauma. Aspiration pneumonia in more than half the people. We'd have to treat all of that, get them through all that trauma, get them through all the medical problems that come with it, get them through the medical problems that led up to their cardiac arrest as well. Their recovery is slow. Their brains are the limiting factor. In the majority of cases, about 75% of people that die of brain issues. And those brains, for the people who do recover, take a while to recover. But when they recover fully. There is a fork in the road for this population. There are not many people in the middle. They either die or they recover fully. They're back to their families. They're back on vacation. They're back with their kids. But again, the recovery is long. So if you look at this graph in the upper right, this is the hospital course just for those that have neurologically intact survival. Most of them are off pump within a week, off the ECMO pump, but they take much longer to start following commands. A week and a half to start following commands. In the hospital side, and again, this really emphasizing the point that ECPR is a system, just like the chain of survival for cardiac arrest. ECPR is just a different chain. It has different links, but you need to be able to give them time and give them treatment at each link. And one of those links is the ICU. You can do everything right in the pre-hospital setting. We can do everything right in the cannulation setting. But if you don't have an ICU team that will just sit on them and be patient and keep the families patient, then people will die that were otherwise able to survive. You just have to give them time. So again, week and a half where they're just comatose. They're there doing nothing. And you have to be willing to sit there and just let them be, let them heal, let the brains wake up. And then eventually 2 or 3 weeks later, they're leaving the hospital. So again, recovery takes time. Physical therapy, a must. Treatment of their underlying heart issues. They may have low EF and have other heart issues as well that we need to treat. For those that go on to die, half of them die within the first 2 or 3 days. These are catastrophic brain injuries. So these people die very quickly, but there are some that have protracted courses in the hospital and still don't make it out. And again, the whole system has to be built around making sure that you screen out who those people are versus the people that are going to do well. So that was our experience just with the program. We just started a program, we started doing it, and that was our experience. We thought we needed to demonstrate that to the world to show that this can be helpful because, as was mentioned, about 2% of the population of the nation in the United States has access to this technology. The only way you make it more than 2% is you convince people it's worth it. So we did a randomized controlled trial called the ARREST trial in Minnesota, in the Twin Cities, multiple EMS agencies, just like it was basically the exact same protocol as the one I just described. They all brought their patients to the University of Minnesota. So it's a single center, but multiple EMS agencies. What we found in this population that got on average 55 minutes of CPR is that we had 46% survival in the group that got ECPR. We had one patient in the standard ACLS group that lived. You know what it's like to be doing CPR and what the likelihood of getting a person back is at 30 minutes of CPR. That's around 5%. You start going to 45 and 55 minutes of CPR, it becomes rapidly zero. We had one person who did discharge from the hospital, trached and pegged. We did everything we could for each and every one of these patients. They all got the same post-arrest care. So that person got everything and aggressive patient care for that patient. And one of them was discharged, trached and pegged, and then died at about 106 days. So if you look at 3 months or 4 months, 0% survival in the standard ACLS group versus 46% in the ECPR arm. Clear evidence that it works. Of course, we wish it was better than 46%, but it clearly is more than standard ACLS. The one thing we noticed, though, is that time is a critical factor. So the blue bars here are the bars from the data from our cohort in the Twin Cities, that whole group since 2015. The orange bars are the amiodarone arm of the ALPS trial. You may know the ALPS trial is a comparison of amiodarone, lidocaine, and placebo in people with shock refractory VF, one shock. They get one shock, it didn't work. They get the medication randomized between those 3 options. But we wanted one that was comparable to our group, so we chose the amiodarone arm. And again, the orange bars. So if you get 0 to 9 minutes of CPR in that trial with very well-trained EMS crews, the ROC Consortium, these people were very well-trained. Some of you may have participated in the ROC Consortium. You had about 67% chance of survival if you get 0 to 9 minutes of CPR. Drops off about 17% every 10 minutes thereafter. That's in the amiodarone arm of the ALPS trial. In our patient cohort, if you get to us within 30 minutes, we have yet to lose a person. We have 100% survival to this day if a patient gets to us within 30 minutes of onset of CPR. CPR the entire time, 30 minutes straight of CPR, 100% survival with ECPR. However, every 10 minutes thereafter, we lose 25% of people. So it is a rapid drop. So time is absolutely critical. And by the time you get to about 60 minutes, it flattens out around 15, 20% survival. It goes all the way out to 98 minutes. That's our longest survivor, 98 minutes of CPR. Unfortunately, there are very few patients that could get to us in that first 30 minutes. And even 45 minutes. The bulk of our patients are, again, the average right around 55 or 60 minutes of CPR. That's just the reasonable amount of time it takes to drive. We asked our paramedics, again, when they were searching for patients, to send us or bring us patients that were roughly within 30 minutes of drive time. I will say you guys are very optimistic drive time assessors because we get patients from far, far away by an hour of drive time, but we never said no. We asked them to try to find those people that were within 30 minutes, but if they were wrong on their assessment, that's fine. We'll still do it. But, it's generally speaking that shorter time frame. But you have 30 minutes of drive time plus 15 minutes on scene and 10 minutes to get them on pump. You're quickly approaching an hour. So it's really hard to get people that quickly. So what we did is we went to them. We set up a program with hospitals on the edge of the Twin City metro area that would serve as our cannulation sites. Our centralized team, which includes highly trained flight medics and nurses from our LifeLink 3 service in town. They participate on our team with our cannulators. And they go to these cannulation sites where they will cannulate in the emergency department. They will cannulate and then bring the patient to the cath lab at that hospital, assess them for coronary disease, treat underlying causes, and then they'll bring them back to the University of Minnesota for their ICU care. That process is shown here. We have a centralized dispatcher at LifeLink 3 who will activate the team, tell them where to go, work with the EMS crew, tell them where to go. We rendezvous at that site and put them on pump. Again, the goal, 15 minutes on scene, a stretch out into the community. This is us doing it in one of those emergency departments. I'm on your right. On the left is one of our flight medics, who's helping, scrubbed in, with the procedure. All of our team are cross-trained on cannulation. They don't necessarily cannulate themselves very often, but they could. They have all the skills and the steps. But we're there to cannulate with them. They also run the pump. They're our ECMO specialists. So instead of having an RT, a perfusionist, a ECMO specialist, a cannulator, a cath lab team, we now have two of us. The two of us are trained in all those different aspects, able to take care of those patients. Now, in the emergency departments, we do have extra helpers available, but we don't rely on them. Oftentimes, the emergency department team will just walk away, and we will take care of the patient in that setting. They may leave us a nurse if they're feeling generous that day, and we really do appreciate that help because it does help offload us. So now, instead of just that red arrow in the middle, which is the University of Minnesota, we now have these black arrows on the outer side. And you can see the orange circles are about 30-minute drive time in the Twin City metro area. You can see how much further it stretches. I don't expect you to know the geography of the Twin Cities. Why would you care? But this will reach as far east as western Wisconsin now. So we can cover a much broader area. And when we looked at our first 4 months, you'll note the 4 months right before COVID, we had 60 patients in those first 4 months. Huge expanse and extension of our program. You'll also see optimism of drive time didn't end. There are a few black circles way up toward the top there. That is well outside the 30-minute drive window. Optimism is key. But we still take those patients. And we still manage to have about 40% survival, even with this extension of the program, doing a little more austere conditions in emergency departments. And basically all of the other percentages held too. The number of people who didn't meet our criteria for the blood gases, the percentage of people that didn't achieve admission because they couldn't get an organized rhythm, all roughly the same, but we still get to the point where about 40% survival of those people that come to us. So what was the next step? The next step is the truck. We built a truck. It's about a foot longer than a city bus. This truck is a cath lab on wheels. It has fluoroscopy. It has ultrasound. It has space for all of us. And we can bring this to the patient. So now there's a giant circle, which is the truck, because now the truck can drive 30 minutes. Other people can drive 30 minutes, and we can meet them anywhere in the Twin Cities. This is the truck. That's the truck compared to an SUV. Those SUVs are our chase vehicles, the ones that we use to go to those emergency departments with lights and sirens so we can get there within 15 minutes. This new truck is very, very big. It's about shoulder height. The floor is, as you're standing next to it. And again, within it is a C-arm and all the tools we need. And that's shown here. So walking up, there's a lift to bring the patient up. You'll see that in use in a second. When you look in there, there's cabinets where we keep all of our equipment. Everything's laid out. We've got a fluoro-compatible table. We have a C-arm for fluoroscopy, ultrasound, a big monitor where we can see everything there. The thing lights up like a Christmas tree when you drive it. And we can take patients, rendezvous anywhere, bring a patient in, load the patient up with this lift. Again, shoulder height. Nobody should have to lift a patient up to that level. Bring them onto this fluoro-compatible table. Take the table, turn it sideways. Then we bring all the equipment in. Here we have 2 firefighters who drive the truck. We need a special driver's license, of course, commercial driver's license to drive this thing. This is our first patient. Lots of people there. You can see the ultrasound is sort of the bottom left. The big screen on the left where we can see the ultrasound, fluoroscopy, and everything positioned right there. We have our 2 firefighters, myself, Dimitri Yiannopoulos, who are the cannulators, and then we have our LifeLink flight crew in there as well. This is the second patient. You can see considerably fewer people. The first one we brought extras, just in case. Second one, much more streamlined crew, just the 2 of us, again, doing the cannulation with the firefighters. This is actually the first case. One of the beautiful parts of this truck is that it's built so that we can do telemedicine within the truck. You can have somebody sitting at home. We built it for VR glasses, so you can actually see all these things and pull them out of the air so you can see different things in higher magnification. And you can sit at home and you can actually be the eye in the sky, help run the code from home while the cannulators are focused on nothing but cannulation. Because you can imagine, this has always been true in our program, but you can imagine the stress of trying to run a code while you're also cannulating a patient and doing these things. So we tried to build it so that we could offload that. We have not gotten to the point where we've been using that routinely, because those of us who are the most experienced cannulators are still going to every case in the truck. But it's built for that. So you see the video. You also see this is the first case, and that the picture in the upper left is the backside of a monitor that's supposed to be turned to the camera. The reason it's not is because the well-intentioned firefighters who drive the truck wanted to make sure they could see the monitor, and they turned it around. And so we couldn't see the monitor on the screen, but we could, ask them for things. But this is the beauty of working through this process and having this truck, is that we can see all these things. Some of them could be piped in directly, some of the information. Other things, we have to have cameras just pointed at them because we couldn't get the data off the device. And so you see at the bottom left there, he has poked the artery in the vein, put wires up both. He's dilating now the artery in the vein, and again, to very large size for these cannulas. We will then start putting the cannulas in here in a moment. Again, those cannulas will go all the way up to the heart. So we use the fluoroscopy both to verify our position in the different vessels and also to correctly position this cannula that looks like a spear, this 25 French venous cannula, which is going in right now. That has to go all the way across the heart into the SVC, headed up to the neck. And so to do that safely, to not poke through a liver where a wire could go, or the heart where a wire could go and curl up, we need to make sure that wire is passed, run that cannula past, and then position it correctly to optimize the flow and the hemodynamic support and stabilization. He pulls out the dilator and the wire, he'll clamp that off, and then move on to the arterial cannula. Meanwhile, we have our team up at the head. So that middle bottom box is actually aimed at the patient's head. There's a big black circle for privacy's sake. But there are people up there with the airway. They're bagging. They're managing the airway. We don't actually do any of the intubation or those things. No more shocks. Once we get started with this procedure, we're focused on the ECMO cannulation so that we can do that safely. After the ECMO cannulation, then we'll intubate. We'll get the airway secured. They may have already been intubated by the EMS crew that brought them. Not always. Sometimes a supraglottic airway. But we'll take care of that after they're on pump. Same with more shocks and other medical management. So arterial cannula is in, and now we're connecting tubing so that we can connect it to the pump. Again, this is pulling the blood out of the femoral vein, putting it through the oxygenator, and putting it back in oxygenated. So you'll see when this gets started that the blood coming out is very purple, blood going in is very red. And you also see that bottom right, which is the CardioHelp machine, again, the ECMO pump. You'll see that the numbers start to increase. We're dialing up the RPMs, which then increases the flow and gets you that hemodynamic support. So you can see now the purple blood coming out, red blood going in. And if you had audio, which you don't need to have, because just imagine people are clapping and exciting. It was the first case. Everybody was very excited. So there's a little bit of a longer pause here than the average case because of that excitement. So in summary, ECMO has become a critical link in the chain of survival. It doesn't replace anything that EMS crew did before. It just speeds up what they did before and gets the patient to the ECPR a little faster. But everything else is still just as critical. Still have to acknowledge the cardiac arrest, still have to call 911, get people activated, still have to do bystander CPR if at all possible. We don't require that, but we would really love if they did. We still have to have EMS crews that arrive quickly, start BLS, ALS, and move through the process, get those shocks going as quickly as possible. Then mobilize the patient. ECPR is a system of care. It is not a pump. It is not a person. It is not a thing. It is a whole system. And everybody in that system is critical. And we have had to train the entire system in our community. And this is the biggest roadblock to getting this started everywhere, is to get the whole system on board. So why is it only 2% of society that has this available to, or at least of the United States? It's because you got to build the system, and that's really hard to do. Multi-system organ failure is ubiquitous in these people. They've had CPR on average for an hour. It is entirely treatable in most of them, and in 40% of them, they will leave the hospital neurologically intact. They deserve the chance to be that way. High quality, 24/7, multidisciplinary critical care, and everything else, surgical care, cardiology care, everybody else is critical for all these patients because they are very complicated and recovery is prolonged, but is very possible for many. Thank you very much for your time, and I hope to see all of you doing this soon.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.